Hello, my name is Stephani Shivers, and I'm the Chief Innovation Officer and Vice President of Program Development for a community-based organization headquartered in New York City called CaringKind. It's my pleasure to be with you here today, and I'm going to be talking to you about our implementation of the evidence-based intervention Reach Texas. And my hope is to both inspire and challenge you by sharing some of our lessons from the real world. To level set for everyone, my goals for today are to discuss the impact that community-based organizations can have on implementing and scaling evidence-based interventions in the community, and to also talk about the barriers and facilitators community-based providers experience when implementing evidence-based interventions. Today, I'm going to be sharing results from a project that we did with funding from the Administration for Community Living. Beginning back in 2021, I was the project director on a 3.5-year ACL ADPI project totaling $1.3 million. On that project, we implemented the Texas version of the Reach 2 intervention. Reach 2 is a widely studied, evidence-based education support program for dementia family care partners. Reach Texas is a community-based translation of the Reach 2 intervention. In this version of the program, a care partner engages with a certified Reach specialist for 2 to 6 meetings over the course of 3 to 6 months, which was a decrease of frequency from the original intervention. Reach Texas was created by Dr. Alan Stevens and colleagues and was tested in a healthcare setting over 10 years ago. The protocol includes a risk assessment, tailored plan of care, and skills training activities focused on the 9 core areas that you see listed in this slide. Our real-world implementation was launched during COVID, which necessitated some adaptations right away. We had to eliminate the in-home visit and switch to virtual face-to-face sessions via Zoom. To practically evaluate the impact of Reach Texas, we did pre-post measures using the Preparedness for Caregiving scale and a survey to measure changes in knowledge about several dementia-related services. And spoiler alert, we did have a positive result, which I'll share more about in a few minutes. But before I go into details, I want to talk more about the context of the program and service implementation in the real world. Let me first start by sharing more about my community-based organization. For those of you who are not familiar with CaringKind, we're one of the country's oldest not-for-profit charities focused on providing care and support for families impacted by Alzheimer's and other dementias. Throughout our 45-year history, we've been one of the leading community-based organizations in the field, and we continue to launch new and evidence-based programs in the real world. We are based in New York City and have a national reach through virtual programs, services, and educational offerings. In 1985, we were one of the founding chapters of what's now known as the National Alzheimer's Association. And in 2015, when the association centralized operations, we assumed our independent status as CaringKind, so we could continue our focus on providing care and support directly to families impacted by Alzheimer's and other forms of dementia. At CaringKind, we serve the full spectrum of those impacted by Alzheimer's and other dementias. We work with those who live with the diseases, the family members, friends, staff, and professionals who provide their care, as well as with residential and local communities in which people live. We deliver a wide range of programs and services, which you see here. We're a standalone community-based organization, and we're funded through donations and foundation grants. We're not tied to an academic institution or a health system. We do not receive funding through Medicare or Medicaid. Our ACL ADPI grant was our only federal funding source. We provide services in person and virtually and in multiple languages, and all of our services are provided free of charge to families thanks to our generous donors and the robust fundraising efforts of our team and board members. I want to underscore this point again. We have no ongoing funding mechanism, and that is typically true for most community-based organizations. We are dependent upon fundraising, philanthropy, grants, sponsorships, and donations. We have to raise our budget funds every year, and we have a fiscal, and I would argue moral, responsibility to generate the greatest impact that is possible for every donor dollar we receive. So at this point, you may be sitting there asking yourself, why is a community-based organization presenting at a conference like the Gerontological Society of America? And I have two reasons. First, I want to change the world. I work with real families and individuals every day who are in desperate need of programs and services that have an evidence base to prove their efficacy. And secondly, we have a problem. We all know we actually have many problems, but there's one in particular I want to talk about today. The answer is 17 years. When we look at the average amount of time it takes to translate evidence-based research into practice, the answer is 17 years. This is not an acceptable option for the people we are serving, who need interventions today. And I think that we are collectively positioned to change this reality if we collaborate differently. If we zoom out and look at how evidence-based interventions are actually created, we can see that they start with a researcher who's creating an intervention for people living with dementia and/or their caregivers or care partners. Researchers create an intervention and then test the intervention with the study participants, people with dementia and their care partners, who are often recruited with the help of a community-based organization. But when that intervention comes into the real world, the community-based organization becomes critically important because the staff in the CBO, or the community-based organization, are the ones who are now responsible for service delivery. In a sense, if we zoom out and think about how this intervention gets to the people, we can almost think of the CBO as the mechanism of action for the service delivery. This is critically important to understand because people living with dementia and care partners don't get direct access to an intervention. The intervention is ultimately delivered by some kind of business entity or organization. And history tells us that typically takes 17 years. We could look back at how silos and academia have created this situation, but I want to look forward and consider how researchers and particularly community-based organizations can collaborate differently to get services to the people. Community-based organizations are strongly positioned to translate evidence-based interventions into real-world practice. And since 2008, the Administration on Aging has provided funding opportunities for CBOs to do this work. Our project, like all ACL ADPI projects, have to include at least one evidence-based or evidence-informed intervention. And since 2008, over 136 million has been distributed to 370 grantees. That's a lot of service providers who are in the business of implementing your interventions. So why do researchers need to collaborate with community-based organizations? Not just to recruit study participants for you, but because you now realize that we are going to be the ones ultimately to get your interventions to the people. We are your distributors. Think of us as Amazon delivery drivers. We get the goods to the people, and we can help you better shape your interventions into a product that we can deliver. And we need products that are lightweight enough, that will fit into a package size and shape we can deliver. We need your products to be ready for free or at least low-cost delivery. So keeping that in mind, let me tell you about our project. On our project, we implemented the Reach Texas intervention with 165 caregiver participants. Our goal was to increase their knowledge of available resources and services and to increase their preparedness and confidence. When our project ended, we had 117 caregivers that were considered completers, which meant that they had the initial needs assessment in at least 3 sessions. And the majority of the remaining 165 participants were still in progress of receiving the intervention. The image that you see here is of our co-branded caregiver notebook that was used as a resource during the intervention, and that Dr. Stevens generously allowed us to update and include information about our community so it was relevant to our local care partners. Here you can see a graphic that I snapped from our activity tracking database that gives you a better picture of the actual service utilization by care partners. The dark purple segments are the actual protocol sessions, but you can see how many of the participants had many more meetings with our staff beyond those one-on-one sessions. This chart shows us that for almost every 2 protocol-related sessions, the care partner needs 1 additional non-related ad hoc meeting. This has huge implications when you think about how much it costs to actually deliver an intervention in the real world with real people, because caregivers have multiple needs that go beyond just your intervention. And as a service provider, we're trying to meet all those comprehensive needs in one way or another on a very limited budget. And so you have to think about your intervention as one part of a whole suite of interventions that a care partner will need over time. To measure our outcomes, we used the Preparedness and Caregiving Scale, and we added an extra question to determine how confident caregivers were to manage distressing and/or challenging behaviors. And here you can see our results on the PCGS. 75% of our participants had an increase in their mean score from baseline to final, which indicates improvements in feelings of preparedness to care for their family member. We also had a significant increase in confidence, with 55% of our participants either reporting a higher score or maintaining the highest score on our added question about confidence for handling challenging or distressing behaviors. We also used an adapted version of the service availability measure, pre and post the intervention, to measure the caregiver's knowledge about 14 dementia-related services. And this graphic clearly shows how we increased awareness on all of the related services. We also received some great quality feedback on the program, and you can see the topics highlighted here had a direct correlation to the topics that were included in the intervention. I'm so thankful for this dementia-specific program, which helped me with many practical care-related suggestions, and also having a professional who's patient, calm to talk with, and to listen to my concerns and challenges. It's truly been a godsend. I'm much more confident caregiver after participating in the program. So hopefully with all these results, you can see that we have successfully implemented this particular program, and we have the data and the outcomes to showcase our accomplishments. So let me wrap up by giving you some specific insights that I believe are critically important for you all as researchers as you move forward in establishing your research agenda. I want to highlight some key challenges and barriers, but more importantly, I want to give you some solutions and enablers that will make it plausible for community-based service providers to implement your evidence-based programs in the future, hopefully before 17 years. The first one is important, and I'm speaking to you as a former home care occupational therapist who loves working in people's homes. As a senior and seasoned leader who has worked in community-based organizations for decades, I have to tell you that in-home services are just not feasible to replicate and scale. As an employer, I have to think about staff transportation and liability and scheduling and paid time travel and paid time off, and all those issues create huge barriers for in-home delivery. Instead, please move towards face-to-face interventions that can be done in an office, at a satellite location, or via Zoom or another electronic means and virtual platform. Secondly, one-on-one sessions are very expensive to deliver. As an employer, I have to think about staffing and reimbursement and scheduling and cancellations and having skilled staff to deliver services when there's a huge workforce shortage that is only increasing. Instead, please move towards small group interventions so that participants also get the added value of peer-to-peer engagement. Thirdly, recognize that training in an intervention needs to be accessible and created in a way that it can be done on a rolling basis. As an employer, I have to think about matching trained staff to the volume of clients that I have. And I have to be able to backfill for staff when they're out getting trained. I need to be able to pull 1 or 2 people at a time for a few hours at a time. So create train the trainer opportunities that are affordable and can be delivered on a rolling basis so that in-house trainers can be nimble to deliver the training according to the needs of the organization. I have to give a shout out to Dr. Stevens on this particular topic because he really worked with us. We started our project with a live training that he allowed us to video. We then created an in-house training option and allowed me to be a master trainer. This option allowed us to train 6 additional staff, with 6 more coming in the new year, and has been critical to the sustainability of this intervention. Because given our staff turnover, I only have 2 of the original trainees still delivering the program. Also think about the frequency and duration of your intervention sessions. As an employer, I have to think about staffing and scheduling and each staff person's own bandwidth to deliver multiple sessions of a service in a day. If you can increase the duration of a visit and decrease the frequency, it makes it easier to optimize the productivity of the staff while also decreasing the number of clients they have to see in a day. Finally, give thoughtful consideration to the necessary credentials and skills that are required for the interventionists. As an employer, we are dealing with significant workforce shortages, so we have to carefully match staff's skill to the skill requirements of the intervention. To give you a practical illustration, I mean something like, don't ask me to send a surgeon to take a blood pressure. As I wrap up, let me end with a few thoughts for your own reflection. I'd love for you to ask yourself, how can you work differently to shorten that 17-year time lag? Please also remember that individuals and families need your interventions, and their taxes are the ones that actually fund your research. Please consider how your work will get the return of the investment back to them. Earlier in my career, I worked in an academic research world, and I truly believe we can shorten that 17-year time gap. I represent just one of many community-based organizations, and I know many of us are ready to partner and collaborate with you to be the change. Invite us into the conversation and your study design process early. Don't just reach out when you need us to do recruitment. Bring us in as collaborators and advisors and research partners. We're ready to help. Just ask. Thank you for your time and attention, and I look forward to connecting with all of you and any of you in the future. Thank you.